Good morning. My name is Robert Lim, and I am very honored to be here. I want to thank the SLS again for having a military committee join its educational program. Uh, this morning, I get the honor of discussing the highlights of day one of the SLS MIS week, and I get to review what happened in our session, as well as a second session about tips and tricks for advanced laparoscopic procedures. Our first discussion was by Colonel Timothy Brand, who discussed the history of the military and the development of robotics. Initially, for the battlefield, which is a little different mission than what most physicians have. But the goal was to multiply the force, to provide more safety for the healthcare providers on the battlefield. And many of the people that I grew up being under their command were some of the contributors to the development of robotics in the military. Currently, there are 13 military treatment facilities that use robotics for surgery. Next, Major Rosemeyer discussed some of the reasons why the military is involved with the robots, and that's bringing the robots to the battlefield. And I would submit that robots are already used on the battlefield in some fashion. Remote control for discovery of improvised explosive devices are being used. And then drone warfare is being used. In fact, the people who operate the drones are many, many miles away from the actual battlefield, taking commands from somebody else who's also very far away. So I guess you could kind of call it telewarfare or tele-battlefield missions are already in place. And we're trying to bring healthcare to that platform also in the military. In the battlefield. Lieutenant Colonel Onfeld then next spoke about adapting the robot for its residents. He's a program director at William Beaumont, and the reason why is because currently there is no curriculum for robotic surgery, and there is no requirement to graduate residency to do the robot, but yet the robot is likely the future of surgery, and the amount of complex laparoscopic cases required to graduate has increased for general surgeons anyway. So robotic training is a necessary part of general surgery residency programs, and that as the years go on will have to be developed and built upon as more difficult cases are done, more types of robots are put out there. The surgery will most definitely have to be part of the armamentarium of a graduating general surgery or any other subspecialty in surgery residency. And then I had the honor of talking about how to get this done as we implement the robot in our own practice. How do we then teach other people? And I think it starts with becoming proficient ourselves in the robot. That may be a very quick learning curve for us, but the bottom line is we can't really teach competency until we become proficient at it. And that's going to take practice, and practice with simulation. And then as we start to do operations, I would recommend that we break the operation into different parts, and they do a certain part of it, and as they show competency and getting more facile with certain maneuvers, then they get to do more and more parts. But one of the keys here is making sure that your OR day isn't slowed down by one procedure. You need to have that turnover down. You need to have the operation go quicker in order to get more cases in. And then the third thing is that education doesn't stop in the OR or before the OR with practice, but it continues afterwards. You record your cases. There's a new concept called crowdsourcing, and there are companies that do this, but you could also post your video on something as simple as Facebook and joining a group, and you can get feedback from experts all over the world about your procedure, about why you did the procedure, about the clinical nature of your decisions to make your intraoperative or preoperative decisions, all very quickly, and that will improve you before and as well as after the surgery. So the learning never stops is the bottom line, and the better you get at doing it, then the more cases you can do and the more cases your residents can learn. I also get the honor of talking about the experts of the SLS and about their experience and their tips and tricks. And we'll start with Dr. Michael McDonald, who talked about urologic complications, focusing on two really big ones, which is ureteral injuries and vascular injuries. Um, he talked about that it's easier to you can treat if you find them intraoperatively, and use things like stents, especially lighted stents, but it's not foolproof, and there should be a quick and low threshold for considering cystoscopy in these cases. As related to vascular injuries, a lot of venous bleeding can be controlled by increasing the pneumoperitoneum, increasing the pressure of the pneumoperitoneum. Um, Urologists and anyone operating in an area of bias should be facile at doing primary repair of major vessels with a 4-0-5-0 Proline on a small needle. And they should be prepared to do this because they won't always have a vascular surgeon around to help them to do this. And it doesn't necessarily mean a conversion to open, but it is something that they be facile at and prepared for. Dr. Jose Nieves Sosa then talked about reducing surgical pain. This was a great talk for all the subspecialties. ERAS protocols should be pretty standard in hospitals these days. They definitely decrease some of the education deficiencies between the patient and the nursing staff. Everyone's on board with the same plan. A lot of their plans are to avoid opioids, which seems to help decrease the length of stay in a hospital. So to that end, they talked about using COX inhibitors and gabapentin, and even before the operation, and also TAP blocks in the operation. A limited OR time, anytime you can get the operation in less than 4 hours, is usually a pretty good deal for the patient. And recommend using acetazolamide to help reduce the shoulder pain or the referred pain that can occur with laparoscopic surgery. Post-operatively, try to avoid the opioids or use them in the epidural or the intrathecal manner delivery. So again, seems to decrease the length of stay. For his specialty, he tried to talk about avoiding bowel preps. That's not very true for the colorectal guys, but in his case, he did recommend avoiding bowel preps. And then anytime you can keep your case minimally invasive and not have a large open incision, that seems to help reduce the surgical pain, which should be a surprise to no one. Next, Dr. Gustavo Stringel talked about the difference between adults and children, and the obvious one, there's very little distance or space inside the abdomen. I always teach my residents that when a patient is lying down, the inferior vena cava is about 2-3 centimeters posterior to the umbilicus in a thin to moderate sized patient, and in children it's less. So with very little pressure, you could be pushing on the vena cava, and that's indicated because 50% of injuries occur with just the access into the patients. You recommend using the Varus needle for children, and then look for points to avoid missing the major injuries, so off to the side. Or in areas that didn't have previous incisions. The complications can happen in anything, the hollow viscous organs, the solid organs, the inferior epigastric and abdominal wall, and then of course the major vascular injuries, both in the mesentery and the retroperitoneal space. Dr. Jessica Ibanez Morano then gave us her talk about doing a single site in surgery for doing a right hemiclectomy and a LAVH BSO. She was able to do this, and the other surgeon able to do this with a 2-centimeter incision, able to remove the bowel through the single port, and then remove the uterus transvaginally. Didn't require much repositioning intraoperatively. She suggested it did increase the operative time, but not appropriate for every surgery, but certainly it's a doable case in the experienced person's hands. Dr. John Morrison next spoke about vascular complications of laparoscopic surgery. He echoed what our pediatric surgeon talked about, which is half all injuries occur upon entry, but unfortunately half are not recognized at the time of injury. Contributing factors included inadequate understanding of the anatomy, a forceful thrust, possibly inexperience. The inferior epigastric vessels are the most common ones that are injured. But a retroperitoneal injury, it can also happen, and it must be explored and treated like penetrating trauma. And in those situations, those cases, damage control is something that can be temporized. What happens to your patient so that you can do aggressive resuscitation and maybe possibly get help if that's what you need in there. But recognition and realizing when you can happen are very important to successfully treating these injuries. Dr. DuCoin next talked about small bowel complications. Um, the Talked about staple line bleeding and some techniques in order to control that. I also had a lot of good advice about the use of surgical energy and the differences between monopolar and advanced bipolar. One thing I've always think is impressive, I tell my residents that the harmonic scalpel gets up to be 300 degrees, sometimes Celsius. So it's very, very hot and takes an average of 20 seconds to get down below 100 degrees Celsius. So you can't use a harmonic and then grab a piece of bowel or else you'll burn right through it. If you suspected a thermal injury, it's like any burn. If it's full thickness, it won't slough off or appear until 3 days later, 2 or 3 days later. So if you suspect one, you should go ahead and repair it, even if it's just putting a Lemberg stitch in the bowel. You should be very cognizant of this because if you think that, it wasn't too bad, it'll be okay, it won't look that bad, especially on the outside of the bowel initially, but it will be bad 3 days when it perforates. For the adhesions, you emphasize the use of traction and countertraction and the use of sharp dissection as opposed to using energy, especially when you're next to bowel. Because it may inadvertently spread to that bowel when you're getting a tight area. And then finally, Dr. Miguel Vasquez Guzman talked about mesh and possible complications of that and the way to treat vaginal, organ prolapse in the pelvis. And he recognized that the first line was through the vagina for this, but suggested that laparoscopic and robotic transabdominal approaches may be the way of the future if they can get good techniques in there to do it and avoid the use of mesh in the future. And with that, I'll conclude my discussion for this morning. Thank you again for this time.